Good afternoon, everyone, and welcome to our Heart and Stroke Presents. We are very excited for this year's Stroke Month webinar, so thank you all for joining us. Today, we are very pleased to be working with our partners, the March of Dimes of Canada, and together we bring you this webinar, From Acute to Community, Meeting the Needs of People After Stroke. Today, we are planning to follow the stroke continuum of care, starting with acute care through to community support and participation. We hope to use this opportunity to share some information about the upcoming acute care guideline to help enhance and support your practice. We will also be sharing information focusing on the transition out of acute care back into the community, where we know support and participation is so important. So a big welcome to everyone who is joining us, and we hope that you find this webinar both useful and enjoyable. So a couple of quick technical pieces. When you join today's webinar, you will be joined in computer audio. If you prefer to listen on your telephone, select the phone call and dial-in numbers will auto-populate. If you need to expand or contract your control panel, select the orange arrow button in the top left corner. Questions are absolutely welcomed during today's webinar, and you can enter them via the question panel. Please enter them at any time during the presentation, and we will have a question and answer period at the end of the presentation. If you would like to live tweet or share your learnings from today with your network, please include the handle for Heart and Stroke and March of Dimes Twitter, as well as the hashtag for this webinar. This webinar is being recorded and will be available for viewing. You can access the webinar after the event on the Heart and Stroke YouTube channel and the Stroke Best Practices website. Today, after the webinar, all attendees will be emailed invitations to complete an evaluation, and this will lead to your certificate of participation, so please complete if you're able. So I am Rebecca McGuff, Stroke Best Practice Project Lead with Heart and Stroke, and I'm joined today by Christina Sperling, who is the National Director of Community Programs and After Stroke with March of Dimes of Canada, and we will be your moderators over the next hour. We would like to begin by acknowledging the Indigenous peoples of all the lands that we are on today. While we meet today on a virtual platform, I'd like to take a moment to acknowledge the importance of the land which we each call home. We do this to reaffirm our commitment and our responsibility in improving relationships between nations and improving our own understanding of local Indigenous peoples and their cultures. From coast to coast to coast, we acknowledge the ancestral and unceded territories of the Inuit, Métis, and First Nations people that call these lands home. Thank you again for joining today for our Stroke Month webinar. I will now pass it over to Christina to review the objectives of today.
Thanks so much, Rebecca, and welcome everyone. We're so thrilled to have you join us and our presenters today to discuss this very important topic. Over the next hour, we will learn a little bit about the soon to be available 7th edition Canadian Stroke Best Practice Recommendations for Acute Stroke Management. We will consider the needs of those impacted by stroke as they move from the acute setting back to their communities and what can be done to accommodate those needs. We will explore how healthcare providers and other professionals working with community-based organizations can offer support to those living with stroke. And finally, we will share with you some of the resources, programs, and supports that are available for those impacted by stroke as they move forward with their recovery journey. Today, we are fortunate to have 3 very engaging presenters with us to share their insights on our topic of acute to community care. First, we will hear from Dr. Shamy from Ottawa. Then we have the pleasure of hearing from Bruce Young, a stroke survivor who is here to share his story. And then we will end the presentations with Dr. Gaboury from Quebec. After the presentations are done, we will leave time for questions as Rebecca has indicated. So please don't be shy, add your questions throughout the presentations in the chat box. Now I'll hand it back over to Rebecca to introduce our first presenter, Dr. Shamy.
Thanks so much, Christina. So our first presenter is Dr. Michel Shamy. Dr. Shamy is an attending neurologist at the Ottawa Hospital, scientist at the Ottawa Hospital Research Institute, and associate professor at the University of Ottawa. He holds a BA in history from Yale, an MD from Queen's, and an MA in the history and philosophy of science in Calgary. He trained in neurology in Toronto, followed by a fellowship in neurovascular and neurocritical care at UCSF, and completed stroke research in Calgary. He is co-chair of the Canadian Stroke Best Practice Recommendations for Acute Stroke Management, director of the Medical Ethics and Humanities Program at the University of Ottawa, and both fellowship and scientific director of the Ottawa Stroke Program. His research program, which explores questions of decision-making, ethics, and the use of evidence, is supported by grants from CIHR and HSFC, among others. Michel lives in Ottawa with his wife, Claire, a palliative care physician, and their two sons, Henry and Arthur. Over to you, Dr. Shamy.
Thanks so much, Rebecca. Good afternoon, everyone. It's a pleasure to be with you today. I am coming to you live from my attic. We have some sick children at home with gastro in the house, so if you hear screaming, that's why. It is my pleasure to kick this off today. I'm just trying to advance their slide. There you go. As Rebecca alluded, I've been fortunate to have research funding from a number of institutions. I have no conflict of interest. I have no relationships with industry. So you've heard a little bit about who I am. I was born in Montreal. Now I'm very fortunate to be working in Ottawa, and I wear many hats as a neurologist, so a doctor who takes care of patients with stroke, as a researcher, as a teacher, as a husband, as a father, and particularly relevant to today's presentation in the role of co-chair of the Canadian Stroke Best Practice Recommendations for acute stroke care. And you'll hear a little bit more about that later. For those of you who aren't familiar, a brief primer on stroke. So stroke changes lives in an instant. This is one of the most characteristic and difficult things about stroke, that you're well one moment and not well the next. Stroke happens in the brain. It's when there's a sudden interruption of blood flow to part of the brain, and so that part of the brain stops working. And when it stops working, you lose the functions that that part of the brain would normally do. So for example, if the problem is affecting the left side of the brain and the language centers, you will be unable to speak. But if it's affecting the right side of the brain and the part of the brain that collects visual information, then you won't be able to see part of the world. There are two main types of stroke. There's what we call an ischemic stroke or a blockage stroke, where one of the arteries, a pipe taking blood to part of the brain, is blocked. And then there's what we call a hemorrhagic stroke or a bleeding stroke, where there is a rupture, a burst of one of those blood vessels, which leads again to blood not getting to where it should be. And slightly differently, pooling in a place where we don't want it to be. Stroke is a common and serious disease. It's the #1 cause of adult disability in Canada, and depending exactly on the numbers, it's the #3 or #4 most common cause of death. But the good news is that stroke is preventable, treatable, and can be recovered from. And we have made huge progress on those fronts over the course of the last 20 years. So what is stroke? What is probably the most important message about stroke for all of you who are not doctors and nurses and occupational therapists and physiotherapists to know about? It's this: it's fast. Stroke is a very time-sensitive disease. Our ability to treat it is determined minute by minute, and so recognizing the signs and symptoms of stroke is the first and arguably the most important step in getting a patient onto the path of treatment. How do you do that? Well, this acronym has been developed through the Heart and Stroke Foundation and is highly effective as something for all of us to use in our day-to-day lives when we're looking to identify the signs and symptoms of stroke. Face. Is it drooping? Do you see your loved one or friend or family member with a drooping face? Arms. Are they having trouble raising their arms? Speech. Are they having trouble speaking? Is it slurred or jumbled? And if you see any of those features, then it's time to call 911 right away. That is the FAST algorithm. Let's say that you've identified a patient as having a stroke. What happens next? Well, we in Canada are very fortunate that we have a very well-organized system of care for people with stroke, starting with what we call the acute treatment, and that's what I'll be talking about mainly today. We have access to care to prevent stroke in people who are at risk. We have access to rehabilitation services to be able to undo the damage that has been done. And then we have supports in the community for people who have suffered stroke. because despite the best treatments that we have and access to the cutting edge technologies that we are going to be talking about today, many patients who suffer strokes are left with some degree of residual symptoms, disability, deficits, and will require supports in their day-to-day lives. Let's talk about acute treatment. The goal of acute treatment is to limit or undo developing damage. We're dealing with a process in medias res. Now, what's important to know about acute stroke treatment is that we had none before 1995. Think of where you were, think of how old you were in 1995. At that point, if you had had a stroke, there would have been nothing that myself or a colleague working at that time would have been able to do to undo the developing damage of stroke. And since that time, there has been significant improvement in the treatments that we can offer patients with ischemic stroke, with blockage stroke. But unfortunately, no major developments as of yet for patients with hemorrhagic stroke. But we are optimistic that some things will be coming down the pipeline in the next few years. In order to ensure that patients get the treatment that they need as quickly as possible, we have developed very organized systems to get people the care they need. And this exists largely on two levels. First of all, is an organization of all of the hospitals in Ontario, for example, and across Canada as designated stroke centers or not. And we are very fortunate that in Ontario, if you recognize the fast symptoms and call 911 and paramedics arrive, they know whether to take your loved one or friend or family member to the closest hospital or to the closest hospital that is capable of delivering the stroke care that they need. And so on this map of Ontario, as an example, you'll see that there are in black the centers that are able to develop to administer the most advanced stroke care. Those in red can do the first level of stroke care, but you'll see there are lots and lots of other hospitals across the province that are not equipped to provide stroke care at this same level. Now, if you arrive at one of those hospitals that is equipped to deliver stroke care, what will be happening is that as soon as that patient hits the door, the emergency doctors will assess them, confirm that this looks like a stroke, and will call code stroke. There will be an announcement that goes out to all the members of a highly specialized team to come rushing down to the emergency department so that within minutes, the patient can be assessed by the experts. They can get the pictures of the brain that they need, which is in most centers a CAT scan, and that decision-making process can start to happen. Here you see an image of me with a version of our stroke team back from 2018 with residents, medical students, and fellows, so trainees who are getting extra specialized care training in how to develop stroke care. Another layer of things that we are fortunate to have in Canada that allows us to ensure access to best quality care for patients afflicted by stroke is the Heart and Stroke Foundation support of Canadian Stroke Best Practice Guidelines. So this is a document that we update every 2, 3, or 4 years that sets out the standards of what stroke care should be. And developing from the original one version of one document that tried to cover acute and prevention and rehabilitation, we now have multiple different modules that are constantly being updated. And as you heard, the 7th edition of the acute stroke module will be coming out very shortly. How do we come up with the recommendations that are included in this document? Well, we put together a panel of experts from all across the country representing our different provinces, languages, gender, race, etc., in order to have a diverse group to capture all of the best ideas in order to keep our recommendations up to speed. We go through a process where we very rigorously review the evidence for all of the specific recommendations that we offer, and then we arrive at a statement. For example, you should receive acute stroke care. And what is new in this edition is that we have not just made the statement, but we have associated that statement with both the strength of the recommendation, how strongly we believe that that recommendation should be followed, and the quality of the evidence that goes behind our making that recommendation. So not just whether we made it up off the tops of our heads, or whether this is something that has been studied extensively, studied in Canada or maybe around the world, in randomized clinical trials, in large clinical trials from across the world, or perhaps in smaller studies. And so we have done that, what we call the grade process, for our different recommendations. This is a new development this year. Let's talk about what those recommendations actually involve. The first major treatment for stroke is something called thrombolysis, is giving a clot-busting drug through the intravenous that can help to break up the blood clot that is blocking an artery in the brain and can lead to early return of blood flow, saving that part of the brain that was struggling to function in the absence of oxygen. The original studies from 1995 suggested that the treatment was effective only in the first 3 hours. Further studies showed that it was beneficial out to 4.5 hours after the start of symptoms, but the likelihood of benefit declines with time. And so the type of recommendation that we would make, again, this is not the final version, but this is the spirit of it, is something along these lines, that all patients who are candidates for thrombolysis under 4.5 hours from symptom onset should receive it as quickly as possible. And that is a strong recommendation based on high quality evidence, data acquired from many randomized clinical studies and real world experiences. You'll see that I use mention here of the drug specifically named alteplase, or TPA. That was the treatment that we had and that was used in our studies in the early and mid 1990s. I'm going to come back to that in a moment because we're going to talk about the update to our recommendations, where we are able to comment on another drug that works in a similar fashion called tenecteplase, or TNK. The second major pillar of acute stroke treatment is what we call thrombectomy, or endovascular thrombectomy. Now, while thrombolysis, clot-busting drug, is a great treatment, it doesn't help everyone, especially those people with large clots in main branches in the brain. And it also, and not everyone is a candidate for this kind of clot-busting drug, depending on passage of time, the use of blood thinners, etc. And so, in fact, since the 1950s, we've been interested in trying to develop ways to go into the brain with devices and pull those blood clots out. And it wasn't until late 2014 and early 2015 that a number of clinical trials, most prominently the ESCAPE trial, that was a Canadian-led study based out of Calgary, established that yes, this treatment of endovascular thrombectomy could be very effective at helping people experience improvement of blood flow in the brain during the first 6 hours after stroke. That now 1 in 3 patients who would otherwise have been disabled will be able to walk out of the hospital with no disability. Similar to the evolution of treatment with thrombolysis, subsequent studies established that in fact that 6-hour window was just the beginning, and that using advanced imaging technology, we can actually identify patients who will benefit from the use of thrombectomy out to 24 hours after the start of symptoms. But again, earlier is always better. This is an example of the kind of recommendation that we would make for thrombectomy. Here you see the thrombectomy suite, the specialized operating room in which we do the procedure. And then here's an example of a blood clot that was pulled out of a patient's brain. All patients who are candidates for endovascular thrombectomy should receive it as quickly as possible. Strong recommendation, high quality evidence. What are the updates for 2022? Well, I alluded to the idea of the newer thrombolytic agent tenecteplase, or TNK. Might it be as good as, or even better than, alteplase, the drug that we've had for 30 years. Why the interest in tenecteplase? Well, it's given as a bolus, a one-time push injection rather than an infusion that takes an hour to run in. And in some environments, including in Canada, it's actually cheaper. Prior studies suggested that it might be just as good, if not better, maybe with better efficacy and less bleeding. And so at the European Stroke Congress in Lyon, France, just about a month ago, a group of Canadian colleagues, including myself, but most prominently doctors from Calgary and Toronto, presented the results of the ACT trial, alteplase compared to tenecteplase. This is the first ever all-Canadian acute stroke trial. We enrolled 1,600 patients from all across Canada and show that in real-world conditions, in the conditions in which we as doctors operate on an everyday basis, the drug tenecteplase was non-inferior, meaning not worse than, meaning as good as alteplase in routine Canadian practice. And so inspired by that development, we are going to update our recommendations in 2022 to say something along these lines. All eligible patients should be treated with thrombolysis as soon as possible, and that tenecteplase is a reasonable alternative to alteplase. Another major area of controversy lately is the question of whether we even need to combine a clot-busting drug, a thrombolytic drug, with thrombectomy when patients are candidates for both. So it has been the standard of care since 2015 that if a patient was a candidate for thrombolysis and thrombectomy, then she or he should get both. Some people have argued, you know what, thrombectomy is so good, maybe we don't need thrombolysis. Two studies out of China suggested that, yeah, in their system, the way that they operate, giving the endovascular thrombectomy without alteplase was just as good. But their system is different. Their treatment times are slower. Their outcomes are not nearly as good as what we expect in Canada. And so over the course of the last 6 months, 3 major studies have added very important information. SKIP out of Japan, Mr. Clean, no IV out of Europe, and SWIFT Direct study out of North America, including Canada and Europe. And essentially all 3 agreed that in systems similar to the way we organize our care, that EVT alone, thrombectomy alone without thrombolysis, was not non-inferior. It was not as good as using the clot-busting drug. And so our updated recommendation for 2022 is going to say something along these lines, that all patients who are candidates for thrombolysis and thrombectomy should be considered for the rapid administration of both treatments. Just a final word about stroke prevention. Right? What are the things that we do to prevent stroke in people who have had a stroke event? This is what we call secondary prevention. For the last 50 years, the mainstay of treatment to prevent stroke has been a mild blood thinner like aspirin. And this was based on work by the Canadian stroke neurologist Henry Barnett in the 1980s and early 1990s. We have now learned that a short course, a combination of 2 blood thinners, either aspirin and something called clopidogrel or Plavix, or aspirin plus something called ticagrelor or Brilinta, is actually slightly better than aspirin alone in the first 3 weeks after stroke. And so our updated guideline statement on stroke prevention that came out in 2021 states that dual antiplatelet therapy is recommended for 21 days after a recent minor stroke, or what we call a TIA. Another important update that came out recently is recognizing that daily aspirin, while it is still a very good treatment for people who have had a stroke or a warning stroke or a heart attack, is not recommended for people who have none of those problems. So whereas grandma used to take 81 milligrams of baby stroke every day, that's something that we would argue against now, unless she had had a stroke or a heart attack or a blood vessel problem. The reason for that is that aspirin can promote bleeding, can promote stomach irritation. And so if you're not in at least a medium risk category, then the side effects of the aspirin will be more likely than benefit. What are our take-home points from my brief presentation today? Stroke is common and serious, but treatable. Stroke management involves acute treatment, prevention, rehab, and community supports. The first step in stroke management is recognition, so act fast. Canadians continue to be world leaders in advancing stroke care. And finally, stroke management is a team sport involving doctors and nurses, researchers, physiotherapists, occupational therapists, speech therapists, community support, social workers, and you're going to hear more about the importance of all of those other members of the team as the webinar continues. Thank you so much, and I look forward to your questions at the end of the panel.
Thank you so much, Dr. Shamy. What a great breakdown of some of the evidence used to support the development of acute stroke management recommendations. And just a note, and as shared by Dr. Shamy, all the statements shared today are in draft form, but we're very excited for the guideline to be released, and we're targeting this fall where the statements will be in final form. Of note, and in the spirit of following the care continuum, I'd also like to take an opportunity to share that in the coming weeks, we'll be releasing a new virtual stroke rehabilitation guideline, which is a new module for us. And this will just be another tool to support people with stroke after they've left acute care. I'll now pass it over to Christina to introduce our wonderful next speaker.
Thanks so much, Rebecca. It is truly a pleasure for me now to welcome and introduce Bruce Young. Bruce Young joins us from Delta, British Columbia, where he lives with his wife of 41 years of marriage, Linda. Bruce and Linda have 2 adult children. Bruce loves to travel and do volunteer work, which also includes building a playground in Guatemala and doing cultural exchanges to France with his students. He has been an avid runner, completing a variety of distances, including 10Ks and half marathons. Very impressive. Bruce's 36-year career as a teacher came to an abrupt halt in the fall of 2017 when he suffered a stroke. Bruce's post-stroke journey has been challenging, and his story is inspiring. And I hope you're all as excited as I am to have Bruce here with us today to share his story. Welcome, Bruce.
Thank you. Thank you for inviting me to speak today regarding my stroke journey. I have a few key messages that I hope to share and illustrate through a description of my stroke and the steps I have taken to build my life to find renewed purpose and optimism to help others do the same. Not all strokes are the same. Some post-stroke difficulties are invisible to others, sometimes making it difficult to get help. Navigating the health system is a challenge with the variety of specialties. Peer support and stroke-specific programs made a big difference in my recovery. An individual's needs for support and change over time. I am an animal lover. One of my dogs, Stanley, was getting old and senile. We had him for 15 years, and he growled only when he was eating. Recently, he had been snapping at our other 2 dogs. Although my son had warned me not to look in his eyes, I hadn't heeded his advice. On Labor Day 2017, Stanley snapped at my nose with broke to the skin, and it all started to fall apart after that. A few days after the dog bite, I returned to teaching for another school year. As always, I left my summer behind and got down to planning for all my classes. I was anticipating working with the debate team, pictured on the slide, and many other student-led clubs. My new teaching assignment was 6 different courses in 5 different classrooms, an insurmountable task at the best of times. I sat at my desk in tears. I could not separate and organize my work. I was overwhelmed, trying my best to be a team player and collaborate with the colleagues I had done for years. On September 7th, I joined my colleagues in the library for the opening staff meeting. 5 minutes in, I was so confused and upset that I had to leave the room. With the help and understanding of a counselor and vice principal, I took the rest of the day off. Through September and October, I attempted to teach. I was experiencing severe headaches along the back of my head. They were not alleviated by double doses of extra strength Tylenol. Planning for and implementing lessons which I had done for 35 years was suddenly overwhelming and difficult. My GP prescribed a reduced teaching load and large doses of medication. My anxiety and headaches continued unabated. Time went on and my symptoms did not stop. On Saturday, October 21st, my son walked into the room, took one look at me and said, "Dad, you're having a stroke." We called 911. Off I went to Surrey Memorial Hospital. In the ER, by chance, I was seen by my neuro-ophthalmologist who ended up following my case. Not knowing the cause of the stroke, I was sent to the critical care unit and put on the strongest antibiotic available. With the help from the CDC, Center for Disease Control, it was determined that my stroke was caused by a bacterium from the mouth of my dog, Stanley. It was discovered that a clump of bacteria had adhered to a chamber of my heart. Within hours of scheduled open heart surgery, thankfully, an antibiotic was found. My stay in hospital lasted from October 21st until early December. Upon being discharged, I was sent home with 6 weeks of a daily antibiotic drip. At the end of 6 weeks, an MRI showed the medical team that I was cured. They had figured out the reason for my stroke and no physical impairments. I had an OT do assessments on my thinking and perceptual skills. I don't recall exactly what the outcomes were. What was happening in my head was quite another story. My impaired vision nixed my ability to drive. My inability to multitask, plan, organize, and follow conversations in a group context took away my ability to teach. What was I to do? Volunteer at the local senior center, my wife suggested, which I did. It was helpful, but I needed more. Then came COVID. Depression and anxiety took hold, having lost my connections to family and friends. I used the BC health program system as my private Blue Cross coverage for online health services. I attended physiotherapy and counseling. It seemed that physically I was doing fine, emotionally I was struggling, but the counseling wasn't helping me. The struggles I was experiencing post-stroke were not evident to those around me. After exhausting therapies and support, and no other ideas and support in sight, it was time for Google. My keywords: after stroke support. Up came the March of Dimes and the Heart and Stroke Foundation. My only recollection of not-for-profit organizations was the work Jerry Lewis did for the annual Muscular Dystrophy Telethon. Thanks to Google, my research for virtual support brought up a myriad of free March of Dimes programs specifically for stroke survivors. Hope. After 2 weeks of tippy-toeing around programs sponsored by the March of Dimes, I started going full tilt, participating in all of the following virtual programs they offered: nationwide stroke survivor group conversations, PERC, a program that aims to help people stay mentally sharp while enjoying group camaraderie. Talk, twice monthly meeting among stroke survivors, facilitated by a counselor. Virtual chair exercises, and a monthly Ask an Expert presentation. Feeling misunderstood by those who had not experienced stroke, I was gratified to talk through Zoom to a room full of stroke survivors who fully understood my cognitive and emotional challenges. Through the provincial and local chapters, I have made so many new friends that have shown me I'm not alone. I'm now being connected with a local after-stroke coordinator at the March of Dimes who can assist me in setting goals related to my current stage of recovery. Pieces of advice. Support from others with lived experience was truly helpful to me. The stroke survivors I have met made an incredible difference in my recovery. Through my new friends, I heard stories of the strengths and deficiencies of stroke recovery programs and treatments across the country. 2, continue to adapt, grow, and find support when and how you need it. It's important to continue to grow and seek support for your own personal stroke recovery journey. My life may be different than before, but your strengths help to move you forward. With encouragement of other stroke survivors, I have become an advocate for better stroke supports across Canada and have launched with Ron Redham a stroke survivor organization called the Stroke Survivors Advocacy of Canada, planning to work closely with March of Dimes, Heart and Stroke Foundation, BC Brain Wellness, and other not-for-profit organizations to improve post-stroke support and services across the country. With heartfelt thanks, no pun intended, I appreciate all the work being done on my behalf and the other 400,000 stroke survivors across Canada. Thank you for your time today.
And thank you very much, Bruce, for sharing your personal journey with us. As you mentioned, everyone has their own experience post-stroke, and having the opportunity to find the support that's right for you as an individual is so important. Both Heart and Stroke and March of Dimes Canada are happy that we could be there for you to provide you with the help that you were looking for, and we definitely will continue to work with you moving forward. So thank you so much again, Bruce.
Thank you.
Thank you. Next, I'm happy to introduce Dr. Isabelle Gaboury. First trained as a biostatistician and research methodologist, Isabelle Gaboury later developed a strong interest for qualitative research and program evaluation. She obtained a PhD in population health from the University of Ottawa in 2009 while working on interprofessional collaboration. In 2011, she joined the Department of Family Medicine and Emergency Medicine at the Université de Sherbrooke in Quebec, where she is now full professor and director of research. Her research program focuses on interprofessional collaboration and quality improvement in continuums where primary healthcare professionals are involved, including the Quebec Rehabilitation Stroke Continuum. As a Fonds de Recherche du Québec Santé Senior Scholar, she is the author of more than 165 peer-reviewed publications and 200 scientific presentations. Wow. Thank you for being here today, Dr. Gaboury. We are excited to hear your presentation.
Thank you so much, Christina. Good afternoon, everyone. I would really like to thank the committee for giving me the opportunity to present the results of my research work this afternoon on the stroke rehab continuum. So let's move. So conflict of interest, I've received funding from the CIHR and the Fonds de Recherche Québec en Santé to do my work. And next slide. Here it is. So as Dr. Shamy introduced the continuum of care following a stroke consists of 4 steps that ends with the community reintegration. And these 4 steps will last between 7 and 14 years according to the literature. The first 2 phases, subacute and acute, has received a lot of attention. There's been multiple clinical trials that have been conducted, and they've received a lot of attention in the scientific literature, much more than the last 2 phases of the continuum, and especially the last one, the community reintegration phase. In fact, 1 in 10 stroke survivors are completely satisfied with their community reintegration. And in the literature, we found that primary care services are rarely mentioned, and they're the entry door to healthcare services. So unfortunately, the literature does not give us a lot of guidance to develop models and care delivery that adequately reflect best practice guidelines. And just according to the Canadian best practice guidelines, community-based services should include screening and risk assessment for depression, physical and psychological difficulties, support and education for patients and their families, management of physical and psychological symptoms, management of functional disabilities, reintegration into social roles, and periodic reassessment of the intervention plan. That's a lot of work. But as I said before, we have very few transition models available, and those available mostly covered often a very short horizon of time. So sometimes it's only planned for the years, the very few years following the stroke event, and even some models only cover some months after the stroke event. So it's really important to work on this from the research perspective. So in order to review and improve the trajectory of care for people who have experienced stroke in the Eastern Township region of Quebec, my research team and I conducted a project in partnership with decision makers and policymakers to understand what stroke survivors and their families experienced during the transition between the rehabilitation and community reintegration phases. And our second objective was to identify facilitators and barriers to community reintegration from the perspective of both stroke survivors and their families, as well as healthcare providers, with a focus on the organizational perspective. So what can we learn from their experience that would help us to design better service delivery models and to improve quality of care? We used to do so, we used very interesting study design. Wait a second, I'm waiting for the next slide. There we go. So a study design, one for the patient or people living with stroke and their family members, the photo voice, and I'll explain to you what it is in a minute. And for the healthcare providers and the community services providers, we use semi-structured interviews, like classic method. So the photo voice is very interesting in field of stroke because it allows you to tell, like for the participant perspective, it allows you to tell your story, to talk about your needs, and to show what is important and valuable. And by design, you do that so you mix participants with decision makers and policymakers to help capture their attention and engagement to improve services. So it was a first for me, even if I'm a methodologist. I hadn't tried a photo voice before, and I really enjoyed that study design. So how we did it. So first, we met with all the participants, the people living with stroke, to give them instruction about the photo shoot, because it consists of a photo shoot. So you send people, so you give them some instruction and you clarify what you're looking in terms of the pictures that you want them to bring back. They go away for a month using either their smartphones or a disposable camera that the project provided them with. And they took pictures that for them represented their experience of reintegration, of community reintegration after their stroke. Then before they come back for a group discussion, they pick their best 3 to 5 pictures among all the pictures that they've taken in the last month. They show them, like you post them on a wall. It's like a, heart presentation, and you took turns discussing one photo at a time and using the showed interview guide. So you basically debriefed your participants according to these 5 questions for each picture. So what do you see in the picture? What is really going on? How does it relate to your life or to your experience as a stroke survivor reintegrating the community? Why did this situation occur, and what can we do to make it change or not, if it's a good thing that you want to reproduce? And you sit the policymakers or the decision makers in the room, and we all discuss all the pictures together. So it lasts about 3 hours, but it was an amazing experience as a researcher, and also I've had really, really good feedback from the policymakers and the participants as well doing so. So What came out of the analysis was 4 main themes that illustrate the journey in transitioning in the continuum from the people living with stroke and their families, and what it means also. I'm sorry, the slide is not moving up. Oh, here it is. What it means for the healthcare providers supporting people with lived experience along the continuum. So one of the theme was access issues. The other one was care continuity, comorbidity and severity of stroke, and asking and accepting help. So we'll go through each theme one at a time, and I'll start talking about the what we got from the people living with stroke experience. Oh, here it is. So all people living with stroke reported difficulties to navigate the system, to identify what was available and for whom, and the system was often described as a maze, with their family members being their only go-to person. So as one said, I just moved to a new city to join my new partner just before my stroke, so I didn't know anyone. There was a long waiting list. He was searching the internet for activities to help regain my motor skills. Here's an example of the games he created for me. So this is one of the pictures that this person brought back to the discussion group as part of the photo voice. So what emerged from the discussion is that sometimes the decision makers were quite shocked that people couldn't have access to the services that they were describing. For example, here, activities to regain the motor skills, for example. And they were shocked that sometimes the services were available, but they were not aware that it was really hard to access, or all the tricks that people had to do in order to have access to these services. So it was a very fascinating experience just to mix the experience of participants with policymakers around the table. In other cases, very long waiting lists were mentioned, and people would have to go to the internet in order to find the services they need. And from a professional perspective, this difficulty in accessing services for their patients was also present for most of the primary care providers we met, especially those living in rural areas. We observed an important misunderstanding of the services offered and the responsibilities among primary care providers and community services. And some said that they were rather unsettled about good practices in terms of community reintegration, whereas they felt relatively comfortable with the guidelines for secondary prevention. So as one primary care nurse said, we don't have any algorithm, no clear instructions when we meet a patient who has had stroke. So it's very important to consider not only the primary care physician nowadays, but to really think about the primary care team that could be there to support people having access or to care or providing care. Next slide is the second theme on continuity of care. Thank you. So not having access to a primary care team, which is unfortunately a glaring problem in the province of Quebec, can often greatly complicate the journey of people with lived experience, especially those transitioning directly from acute care to after stroke programs. So as one said here, actually it was her family member who related to the fact that she could not have access to equipment loan because she doesn't have a family doctor. So this is a picture of the building where the loan for rehabilitation equipment or technical aids is done. She reported that she did not have access to it because the equipment was only available with a written request from the family physician. And this is another example where the decision maker present during the discussion explained that there were other ways, in fact, to have access to equipment, but in fact, one of the other ways was to get access to a social worker in order to have the prescription, which is not really easier than having access to a family doc. So continuum of care for the participants who had access to a primary care team was much less of an issue. So this has a layer of complexity onto the difficulty to navigate the system. However, from the professional perspective, care continuity along the continuum was also difficult to maintain due to poor communication system among the stroke continuum phases and complex reference procedures. For example, one of the community service worker described, we were talking about the difficulty to access care, and she said, I think one of the reasons, and this is an hypothesis, is that unfortunately we're still not really well known within the network. When I talk about the network, obviously I'm not referring to the rehab center, but precisely to primary care physicians. So she was describing how these like primary care teams were not aware. So sometimes patients would know about their services, but their health teams was not aware that it exists. So the first two themes of this research underline the importance for community organization to be known by patients, but also by primary care professionals who remain the gateway oftentimes to many other services. It also highlights the need for a care navigator for the people with lived experience and their family, and this at any time during the continuum. So remember, 7 to 14 years, because their needs might not be expressed right after the event or after the rehabilitation phase, as we will see in the next themes. This is a picture of one of the participants who had cancer after his stroke event. So as a few people or a few participants describe, unfortunately, a few people with lived experience unfortunately related to the fact they gain access to services often related to psychological health that they thought would have access to after their post-stroke condition, but only weeks or months later. So when they were diagnosed with another health condition, so such as depression, one of the participants mentioned that she had a very major depression 2 years after her stroke, which was probably an effect of her stroke, but it took a lot of time before being diagnosed, and a cancer. So as one said, it's like cancer puts you on a highway in terms of services. It makes them more accessible, but unfortunately, it's quite unfortunate that these people could not have access to services before they had another health condition that would change again their life. And finally, the last theme. So regardless of severity of stroke, access to primary care or access to a network on whom you can count on, asking for and accepting help from others was a theme shared by all participants, all people living with stroke or with lived experience. This was mentioned as a step that marked profoundly their reintegration into the community and can take different forms at different points in time, so depending on the journey. As one patient mentioned, it was my physician who offered me help, but I refused. My wife was a little upset, so she said, "You need help. Why did you refuse it?" Well, in my head, I was proud, so I could not accept it. So they were really discussing this theme about a part of their journey, getting to it's like a reality check where you realize that you're no longer able to do this or that like before, and you need help. And even for the family members, that was mentioned as a step in their reintegration into the community, or reintegration into their new life. So in terms of discussion, the photo voice, I told you before that I really enjoyed this study design, but and it was because it allowed participants to be involved in not only the collection, analysis, and development of action-oriented strategies. And the participation of decision makers and policy makers was key to facilitate concrete changes into the continuum, especially in this region of Quebec, where the research took place. So we observed gaps between the Canadian practice guidelines recommendation and the service offered that highlight the need for the primary care team and community-based workers to play a more significant role in the continuum, and the need for a care navigators and services such as the after-stroke program for people with lived experience. So my key messages, participation of decision makers throughout the research process so that research doesn't is not shelved and forgotten. So that was key for me. Need for the primary care team and community-based workers to be aware of the services that are available. And finally, need to foresee support for patients and families over a longer period of time. So thank you so much.
Thank you so much, Dr. Gaboury. What incredible and impactful research. So thank you so much for sharing it with us all. At this time, we'll ask all speakers to please turn on your cameras, and we'll use this remaining couple of minutes for questions. And the first one is actually for Bruce. And I should say before I pass it over that there's been plenty of talk in the chat question box, just thanking you so much for sharing your story. Bruce, if you're able to come back on. We just don't see you, but I think you're unmuted, so I'll ask you the question. What is some guidance? Hi, there you are. What is some guidance or advice that you would give to family or friends supporting somebody who's had a stroke?
What I see is the medical community is doing a fantastic job, thanks to Dr. Shamy and his teams, to provide stroke recovery programs, and then the work that Dr. Gaboury is also referring to, the medical community, who is also providing, working to try to provide services right across the country. And what I've found myself, and that's why I formed, I and Ron Redden formed an organization to look at the lived experience of the variety of people who are stroke survivors, because I find that their comments or questions or concerns don't tend to be addressed by the medical community or by the professional community. So my piece of advice is that March of Dimes is doing some of this. They often send volunteers in to talk to stroke survivors when they're in hospital, and also before a stroke survivor is released, the medical community should take some time, even a half an hour, with a social worker or someone else who is assigned to this individual when they're released from hospital, to kind of outline what are the services or supports available, which includes March of Dimes and Heart and Stroke and other organizations, as well as the medical community, to ensure they feel informed about what their future is going to look like.
That's great. Thank you so much, Bruce. And we've had a couple of questions all come in. I'll direct these to you, Dr. Shamy, around some of the T&K pieces that you shared. So the first one is, will patients and family be able to come in and request which thrombolysis drug they prefer?
Certainly not yet. So the first step is just to say that the study that I alluded to that showed the non-inferiority that tenecteplase was just as good as alteplase was only just presented a few weeks ago. It has not been officially published yet. And so for a drug to be approved for use in Canada, there are a number of governmental steps that have to happen. So those have not happened yet. They are in the process, but they haven't happened yet. If the drug is approved for use for stroke, which we expect that it will be, then I expect that most likely it'll be a hospital decision of which drug they'll stock, because often, hospitals will buy these things in bulk rather than having a lot of 75 different medications. And then it will be a medical decision, really, on behalf of the physicians involved, as to whether there is a reason that one would be preferred over the other for a particular patient. So I don't expect that it'll be something that patients will be able to request by name. I also would like to share that I don't think that either treatment is bad. And so the point is that whichever one you're getting, you want to get it as quickly as possible. And the way that your system locally is organized will be more efficient to get that to you. That's the right way for it to happen.
Great, thank you. And you sort of answered this one. So just if you have anything else to add, what do you think some of the challenges will be to get the drug available in hospitals? More of a systems level question.
Yeah, that's a great question. So tenecteplase has been around for about 15 years and is the main drug that we use for people with heart attack. So when you have a heart attack and there's a blockage in an artery in the heart, the heart doctors have moved towards using tenecteplase. So it's actually more available than alteplase. So I don't think that there's going to be a big barrier in terms of getting access to it once it goes through the appropriate regulatory approval processes.
Wonderful, thank you. And I'm noticing our time here, we've got one last one for Dr. Gaboury. Is there any way that photo voice could be integrated into other stages of care, for example, during like the rehabilitation phase?
Of course, it's something very flexible, and it's actually a very good way to collect data. Sorry, Amazon. So 2022. It's actually a very good way to collect data from people with aphasia. We know that there's a lot of people with stroke because it gives them another way to express whatever their experience without the words. So, and it's quite powerful. So you know, a picture is worth 1,000 words. This is exactly what the photo voice is giving you access to. So I highly recommended it if you want to use it into another phase of the continuum.
That's wonderful, thank you. And again, mindful of the time, just extending a big thank you to everyone who has joined, and on behalf of the speakers and Christina and myself, thank you all, and we look forward to hearing back from you in our evaluations, but otherwise have a great rest of your week. Thanks everyone.
Thanks so much.
Thank you.